Thank you, Dr. Srini. I think we've been doing this year on year, and my topic will be repeated iris touch during phaco. And what is that next? I'm sure most of you who are doing phaco have at some point of time got this problem, and you know what the iris is going to do you. It is not going to leave you. It is going to follow you, irritate you, and make your life miserable. So that, so what exactly? So that's it. Now once you touch, you're done. The iris is always going to come to you all the time, and until you go out, and sometimes you feel like as if you just cut off the iris and go ahead with the surgery, especially if it is subincisional. So what are the causes? The main causes are again, especially beginners not respecting the central safe zone. When I mean central safe zone, the idea of central safe zone is the definition is clear for all of us, but when we go inside, we forget that simple fact that apart from irrigation, any aspiration phaco should be done in the central safe zone, not beyond the central safe zone. If it is a small people, obviously in IFIS, and high fluidic dynamics, and in case of surge, that is what exactly happened there. So what do we need to do? What do we need to do? We need to reduce the fluidics the moment you have that. Ensure that you respect the central safe zone and the aspiration port away from the iris. And you can use the second instrument if you are good, but as beginners, if anybody beginner is there, it becomes tough. Then iris hook or some rings might definitely be of some help for you. So the same case, as you keep doing, you just stop there, and luckily that is the simple touch. It was side away. What you do is turn that, and you have enough space here. You do all the phaco here, rotate the nucleus towards that portion, and you can go ahead and do the surgery. And again here, you have to make sure that you respect the safe zone. Then using the second instruments to block the iris. See, if you go ahead, you can do that. And in this case, I am showing as a IA, but even in phaco also it does happen. So what you do is just take a Sinskey hook there, keep it as a guard, and then you can go ahead and easily remove even the subincisional cortex. And sometimes if it's in the other side, like here, the iris will get stuck into it's a blessing in disguise in the side port. It's a blessing in disguise. You still can go ahead and do. And aspiration port, so you just have to make sure that the aspiration port is always away from the site which you have touched. The other iris parts will never come to you. It is only these portions which keep coming to you. So all the aspiration you do with the aspiration port away, with that you can go ahead and somehow manage. But in the very severe cases, you may have to use 1 or 2 hooks. Usually because the touch is on one side, you can use a single hook. But if you have a very small pupil, you can go for multiple hooks or a ring and go ahead and do. The base idea is respect the central safe zone and ensure all your fluidics and other parameters are within the central safe zone. By this, you should be able to ensure that even if you have a bad touch, one is obviously prevention. The other is if you have 1, 2, 3, plan A, plan B, plan C, which is going to help you out. Srini, can I do this next one? Yeah. I finished on time. Probably we can have some discussion after my second talk. The second talk is mine is a wound burn. Technically, wound burn is called corneal incision contracture. I'm sure all of you again would have at some point of time, but the pathology basically here is what happens is it's characterized by corneal tissue whitening, basically tissue contracture, wound gape, striae, and distortion. Here what happens when the temperature at the incision reaches 60 degrees, the burn is so fast, within the first 3 seconds it happens, and the incidence is very rare, of course. Now what is the cause? The cause, you have to understand what are the causes, mechanism. So mainly there is 2 sources of heat generation. One is during electric energy to mechanical, that is the piezoelectric, and the frictional heat when the vibrating phaco needle comes in contact with the sleeve. So the sleeve and the conversion of electrical, that is the heat generating part. So what actually happens is, everything goes well, you won't have a problem. Most of the time we feel that it is when you use high power, that is when you get, but that is the confounding factor. The main factor is either the irrigation is less or stopped, or the aspiration is blocked. So these are the two major first line things. The moment you have something there, if the irrigation is low or if the aspiration is blocked, that is when you have to make sure that, okay, now I may get a problem. So before you even proceed, you should ensure. The confounding factor is power, high power. High power is not the first cause. The first cause is irrigation, lower irrigation. What is the effect of thermal energy on the corneal layers? On the epithelium, it is no sequelae, it just causes coagulative. By next day you are normal. It is the stroma. It is the stroma, it causes irreversible contracture, and that is where we all end up in problems. Endothelium, obviously, it is only a cell loss. 1 or 2 days you will have some edema, few week, the adjacent cells will take over. So the problem is how you are going to manage the stroma. So as you said, dense cataracts is a confounding factor. Type of settings, when you are using, nowadays most of us don't use continuous, but those of you are using now can switch over, especially if you are doing the divide and conquer, you could switch over to the hyperpulse or pulse or micropulse modes. That definitely, because it gives you the gap, the cooling gap in between, so that will help you. And make sure that you use excess additional phaco only on occlusion. Before and after you can avoid, so thereby you use less of the phaco power. And obviously mechanical techniques like chop will be of much help. So this is one other cause of sleeve compression. When I say when you have a sleeve compression here, if it is here, there is fluid passing through. The fluid should be passing in through the sleeve outside, and also should be aspirated. When the fluid is coming in and going out, the temperature is controlled. If either of them is blocked, so that is when you end up in wound heats. The other major cause is sometimes thermogenic, that is dispersive effect, especially when you use these viscoat, which are very high dense. They can go and block, and then you go ahead. Initially what you will have occlusion. Even without the tip getting occluded, you will have occlusion sounds coming. That is when you have to be careful. Or you may have this milky white sign, which indicates that, okay, there is a occlusion block. If you keep going ahead, that means the irrigation aspiration is blocked, the wound burn is going to happen. So be careful when you have white cloud signs, lens milk sign, leak incision. That is, you will have the bubbles there, and you will start seeing initially. You have only 3-4 seconds in case there is complete blockage of irrigation aspiration, and if you press it, within 3 seconds you will have the wound burn there. So that you have to be very careful. That is why you have to look for these signs. So what is the sequelae there? Usually it is manageable, especially in the hard cataracts, but if you really have it because of the blockage, then there will be fish mouthing, which is very important, because the wound, though it appears you are closed, will not close. That is where management becomes very important. Prevention is very important. First, test the fluid, test the inflow irrigation. Many times the irrigation water is over, you are doing the 3rd case, 4th case, water is over, you just go in, and that is when you get the wound burn. So check for it, see for the compression of the sleeves, use appropriate settings for the nuclear density. Unless otherwise required, don't go for the high settings, and avoid overfilling OOD. This is one thing that most of them, there are some people who actually go in, first aspirate the central part of the visco and then go ahead with the phaco per se. So that is a good technique, because sometimes we ourselves don't know what type of visco we are using, and many times we are going and keeping on filling with the, especially if you are using viscoat, that is very, you have to be careful. Create a fluid pocket, aspirate the anterior cortex initially and the part of epinucleus, and once you see the nucleus, then you can go and do your trenching or your regular. That way you are sure that there is free flow, there is no obstruction to the aspiration. And be alert to visible signs of decreased fluid flow. That is the lens milk sign. That is very important. That is one sign. And the other sign, important sign, is there is occlusion. Be careful about the ears. your music, occlusion sign without the tip getting occluded. That means there is aspiration block. So that you have to be very careful. Treatment, most of them you can manage. Fish mouthing of the section is very important. Many times we overlook it. That is one of the causes for post-operative. So if you are not sure, you can do a Seidels test and you should suture. I have 1 minute time. Yeah, okay. So you have to suture, and the suture technique also, many things have been described. I'll just go in brief about that. And if it is severe, we may need for some AIMT scleral patch graft or pericardium patch graft. Mostly we can manage with suturing and wound suturing with BCL. The only disadvantage at this point of view is high amount of post-operative astigmatism, that you have to be very careful. So most of us do put these radial sutures. In such cases, you have to be careful, recheck, because the radial sutures will not be sufficient, especially if there is fish mouthing. Some of them, what they suggest is use the anterior the roof and directly to that. Don't involve the posterior, because our problem is the fish mouthing. So to avoid, because you just put a radial suture, the fish mouthing will not be solved. So one is that. The other is use a compressional suture, horizontal mattress suture. So one radial suture and one horizontal suture. That's the mattress suture. If I have time, I'll just go through this. And most of us now, with the advent of BCL and cyanoacrylate glue, we are managing with that, but it takes a long time. Post-operative sequelae will be, you have to keep in mind those things in mind. The other is, there is a conjunctival flap. Use a double-armed 10-0. Go through the superior, the conjunctiva from one arm. The other is from this side into the sclera, and then you just tie. It goes below, and the wound is nicely covered. This is in case you have fish mouthing where it is not closing, and there is a nice burn with corneal contracture, the stromal contracture. And obviously, in severe cases, we can go for very rare scleral cancer, but these are there theoretically. We can look into it, very rare. And autologous Tenon's plug also is there. The same thing, you just go and plug, it gets healed very well. But with the advent of cyanoacrylate, this becomes glue, this becomes obsolete. And pericardium, I don't think anybody has done. That's basically for theoretical purposes. Thank you, Dr. Srini. Anything discussions we can have later?
Thank you, Umesh. We will do the discussions